Inspection. Begin by inspecting from the front with the patient standing. Look for symmetry of the foot and ankles, toe alignment including hallux valgus, bunions and clawing of the toes. Look from the sides. Look for the foot arches. Does the patient have a pes planus, a flat foot, or a pes cavus, a high arch? Look for any footwear. Inspect the footwear for insoles, heel raises, and any uneven wear around the surface. Inspect the patient walking. Look for the heel strike, the stance phase, and the toe push-off. Ask the patient to stand on tiptoes. Look for any varus or valgus deformity at the heel. With the patient on tiptoes, you can also again look at the foot arches and also the soles of the feet. Palpate along the border of the Achilles tendon. Feel for any tenderness around the tendon. In particular, feel for Achilles tightness, varus and valgus deformity, a Haglund's deformity at the calcaneum, and any tenderness around the insertion or around the retrocalcaneal bursa. Inspect the soles for symmetry of the feet, toe alignment, again looking for hallux valgus of the great toe clawing, bunions of the first MTPJ, bunionettes of the fifth MTPJ, scars, calluses, and any swelling or erythema. Palpate along the bony landmark, beginning with the medial malleolus and working your way around the medial border of the foot, down to the calcaneum, and then up to the forefoot and midfoot joints. Palpate across the MTPJs and each toe systematically, before moving onto the lateral border and finishing by palpating around the lateral malleolus and the anterior ankle joint line. Squeeze across the metatarsophalangeal joints. This allows you to identify metatarsalgia and also to pick up a Morton's neuroma. By carefully squeezing across the metatarsal heads, you may well feel the small pop sensation of a Morton's neuroma. Begin with active movement. Ask the patient to dorsiflex their foot from 0 to 45 degrees, plantar flex from 0 to 20 degrees, evert their foot by turning the sole outwards away from the midline, and invert their foot by turning the sole inwards towards the midline. Passively move the foot yourself. Isolate the ankle joint by holding one hand on the tibia proximally, and then move it through a full range of movement, assessing for any stiffness or pain. Then work down to the mid-tarsal joint, isolating the heel with one hand and holding the toes and moving the foot through medial and lateral rotation about the tarsus. You should also then move each MTPJ systematically. Special tests. Anterior draw test. The anterior draw test assesses stability around the anterior talofibular ligament. Place one hand behind the heel with your other non-dominant hand stabilizing the ankle joint on top of the tibia. Pull the heel forward to stress the ligament. If the ligament is lax, suggesting an injury to the talofibular ligament, there will be approximately 8 mm to 1 cm of movement. You should compare this to the opposite side in case of hypermobility. Wash your hands, thank the patient, and then summarise your findings. You should also state that you would like to get an X-ray of both the foot and ankle joints and would also assess the joint above, in this case the knee.